Hi everyone, this is Jason Profetto, and I'm going to be doing the clinical skills orientation for our incoming class. So if you are viewing this, that means you have been selected to teach clinical skills in MF1 for the McMaster Undergraduate Medical Program. As I said, I am Jason Profetto, I'm the Chair of Clinical Skills, and I first want to thank you very much for participating as recruiting preceptors for clinical skills in any of our undergraduate teaching requirements is always challenging, and we really appreciate whenever somebody commits time, energy, and enthusiasm to the process. So thank you very much. So we're going to go over a couple of things today. We're going to take you through a little bit of a presentation first, and I'm going to show you the manual, and we're going to come back to the presentation. So firstly, an overview of McMaster University's medical program is 3 years long, and it's broken down into two main components, and that is the pre-clerkship and the clerkship. Pre-clerkship is what we're going to focus on because there's three main mandatory parts here, and that's tutorials, professional competencies, and clinical skills, right? So the pre-clerkship itself is about 15 months long, and it's broken up into 5 medical foundations, MF, so medical foundations 1 through 4, and the last medical foundation is the integration foundation. So just to understand that there's going to be 3 different parts of the curriculum that are mandatory in pre-clerkship. This includes the tutorials, pro-comp, and clinical skills. So the tutorials, this is all small group learning with facilitators, tutors, or clinical skills preceptors. Tutorials is where the students are going to be discussing more like the detailed academic, knowledge-based content of a topic that's being discussed. And a good example is if you think about respiratory disease, they'll get into like the pathophysiology of COPD, the diagnostic criteria, spirometry, etiologies, etc. These are small groups of 7 to 8 students, and these happen actually twice per week. So it's a 3-hour session, and it happens twice per week, and there is a tutor, which is usually a staff doctor, that facilitates these tutorials. Pro-comp is in small groups as well, but it's 10 students, and this is a different group than tutorials. So tutorials and pro-comp are 2 different groups. It'll be 3 hours per session, and it happens every Tuesday morning between 9 and 12. So it's 1 session per week. And there's 2 co-LFs, or longitudinal facilitators. One's a doctor and one's a non-MD. And in pro-comp, there's more discussion around ethics, communication, certain vulnerable or structurally vulnerable populations, equity-seeking groups, things around like indigenous health, LGBTQ, trans-specific topics, and even things on public health, economics, and that sort of stuff. Then in clinical skills, these are also small groups, but this is the same group that the tutorial group is comprised of. So it's the same 7 to 8 students that are in the tutorials. And this is similarly a 2 to 3 hour session, usually closer to 3 hours. And then this is 1 session per week. And this is run by 2 resident preceptors. So all the residents that are actually viewing this orientation are going to be paired with a partner resident that you guys are going to be teaching together. So clinical skills, and when we say clinical skills at McMaster, because other schools use different terms like professional skills and medical skills, and there's a few different terms for this, we call it clinical skills, and it's primarily a focus on understanding how to take a history or to perform a physical examination. But there's some key components here that are in addition to this, and that's the introduction, or sort of like the understanding of like diagnostic testing and how that fits into history taking, physical exam, and starting to think about assessments and what we're looking at. Obviously, that's a bit more of an advanced topic compared to what a first-year student needs to know, but it is a key component in the learning process. And then, generally speaking, as you know, there's a lot of history, a lot of physical examinations in clinical skills that may have poor evidence or limited evidence behind it. So it's really an understanding as well in terms of how we integrate our understanding of evidence and knowledge and when to apply certain clinical skills that might be low yield or high yield, and starting to get into some of that. So that's what we call like the clinical decision making primer. But really, this is a focus on history taking and physical examination. So there's going to be weekly sessions, as we said, and these will be 2 to 3 hours in length. There's going to be a manual that has the content and the schedule that we're going to get into in a second. Each group has 2 resident preceptors, and then the main goal of clinical skills sessions is to teach a certain clinical skill with the group, but then to have time to practice and directly observe the students perform the clinical skills and provide feedback. You can teach clinical skills basically anywhere in the McMaster hospitals, and that includes not only Hamilton-based hospitals, but Hamilton, McMaster, associated hospitals. So that's anywhere from the Halton area to Brantford to Brampton. So anything that's appropriate, but these are going to be students that are in the Hamilton campus. There is something called the Center for Simulation-Based Learning, or the CSBL, which is in the McMaster Hospital. It's 1M and 1G. That's the location on the first floor. This is specifically a clinical setting that is designed and functions for teaching purposes. So the medical students and the medical program use this, but so does nursing, physician assistant, physiotherapy, occupational therapy, etc. So there's a variety of rooms available that can be booked and used, and there's whiteboards and otoscopes and fundoscopes and blood pressure cuffs and the whole thing. You can also use community clinics if it's appropriate, so like family medicine offices or different types of clinics that have space that would be appropriate and that maybe you're working in and you have permission to use. I mean, it's always, I think, critical to make sure that it's a reasonable request for students to travel to. Like if you're going to ask students to travel 45 minutes to a clinic, I think that might be a bit much, especially when a lot of these students are based out of the Hamilton campus. It's very important too that we understand and appreciate that clinical skills needs to be taught in such a way that we can practice it as well, and we need to practice it on patients, right? So there's a few ways of being able to practice it on different patients. The most common ways to get SPs are what's known as standardized patients. We have at McMaster a standardized patient program that actually functions to create cases, to train patients, and to set up a pool of patients that's available for our program to use in order to teach medical students, or even for things like OSCEs and practice sessions as well. So these can be booked through the standardized patient program. All of those details will be available in our frequently asked question sheet. And each group is allowed up to 8 hours per MF of standardized patient hours or bookings. You can also use real patients on a ward or in a clinic. And I'm just going to jump down to St. Peter's Hospital. St. Peter's Hospital is a branch of Hamilton Health Sciences and St. Joe's Healthcare that has complex continuing care. So it's almost, sometimes it can be used as a transition from hospital to community, but also patients that are more complex and have multiple comorbid issues can be there. So you can also book patients. So these are real patients that are receiving care through McMaster. Through the St. Peter's program, you can book patients. And what ends up happening is we have an administrator at St. Peter's that will vet the patients that they think are most appropriate and safe to use. They will speak to the family and or the patient to obtain proper consent, and just to make sure that they understand that they would be contributing to teaching and what it would involve. And generally speaking, many patients and many families are very keen to help and interact with medical students, so it's a very collegial and supportive process. Anytime, so like standardized patients, more specifically real patients, or St. Peter's Hospital, which is also real patients, it's key that you explain what you would be doing and how they would be contributing to teaching and how students would interact with them. And it's important to obtain consent, so verbal consent. And I would have this conversation with the patient and, if appropriate, with the family as well. But generally speaking, people are very agreeable to this. There's a comment there on student colleagues, right? And this involves students practicing physical examinations on one another. It's interesting in Ontario and Canada because different schools have vastly different policies on this. Anywhere from like a sensitive area exclusion policy where you can examine anything less the chest, the anterior chest wall where there are breasts, genitalia, which should be a bit more obvious, and pelvic, anal, rectal regions. Some schools have a policy where you cannot examine anything on the torso, abdomen, or pelvic region on student colleagues. At McMaster, we don't have a firm policy one way or another. It actually has not really been an issue for us. But what I've been doing over the past few years is cautioning students and cautioning preceptors to use their better judgment, right? So this is obviously an opt-in process. So we should not assume that students have to be participants in clinical skills teaching with one another. We should include students that are comfortable in doing this, and I would use your discretion. So if we're going to be doing a respiratory exam, I do not think it's appropriate for a student to take off their shirt, for example. This is a case where you can tell students to wear a t-shirt and you can examine over the t-shirt. I similarly would not focus on how to do a respiratory exam around a breast tissue region on a student colleague, because I think there's safety concerns and ethical concerns in doing that. But also auscultating the posterior chest wall or the back, or doing a blood pressure on an arm, or listening to certain parts of the anterior chest wall, I think, or examining the legs and the feet, for example, in most people is probably okay. But here I would just ask that you use caution and reason with doing this. And if there's ever any concerns, let me know. So the content and the agenda, right? In clinical skills, there's a lot of stuff that has to be taught. Medical Foundation 1 is currently a focus on an introduction to communication, the respiratory exam, the cardiovascular exam, and some hematological peripheral vascular stuff. So that's going to be in the clinical skills manual, which I'm going to show you shortly. And it's important to know that this clinical skills manual has been an iterative document that's been created, developed, revised over quite a bit of time with significant input from students and staff, and it's been a tremendous amount of work. What I have available at present is only Medical Foundation 1, because the medical school has undergone a curriculum renewal and we've changed the order of the MFs and some of the content. So this is actually a revised version of the Medical Foundation 1. It's also important to understand that across Canada, we have a national working document for clinical skills through the faculty of AFMC. And basically, this is a document that the different schools have agreed upon in terms of the standards of performance and understanding of the different clinical skills for pre-clerkship, clerkship, and what should be performed. So, for example, at the end of pre-clerkship, it's expected that a student can, with proficiency, perform a blood pressure, whereas a pap smear, a student is expected to understand the basis of the examination and why we perform it, but they are not expected to perform it with proficiency. So I'll show you that in a second as well. And then so this last point is actually a big point. This is the first year, well, we've been doing it a little bit over the last couple of years, but we've really changed the document to be much more diverse or diversity inclusive. So what we have done is we've identified through a needs assessment and some research and some review and auditing different areas of clinical skills that requires better integration of diversity and inclusion. So for example, the four most important areas that we identified was how to tailor clinical skills to include important pieces for people of color, especially with regards to like the dermatological exam or jaundice or that sort of thing. The second one is how to tailor the clinical skills examinations for individuals with disabilities. And a good example of this is you would generally teach to do an abdominal exam with somebody laying on a bed, but for many people with a disability that are not able to ambulate or use their legs, they may not be able to safely get onto a bed. And what do we do in those situations? The third one is it was supposed to be a bit more specific to intersex and trans populations, but it generally is LGBTQ more LGBTQ sensitive and specific. So there's different things, especially on trans sensitive health, that we've included. And then the last one was individuals with different body habitus and BMIs, and how to tailor certain parts of, for example, the abdominal exam around that. So I'll show you some of that stuff as well. So this is a point where I want to take you to the clinical skills manual, and we are here. Okay, so this is the clinical skills manual, and you'll see. So for MF1, this is actually almost 100 pages long, and you can see what the amount of work that's got into it. So there's an introduction part. This is the National Clinical Skills document. So that's it'll hit a hyperlink and show you this. So this is something that you can refer to if you're ever curious. So if you go to the respiratory exam, for example, you can see that there's certain specifics, the rationale, the techniques, some of the evidence behind them, but also for a pre-clerk and for a clerk, the different levels. And these all have, there's legends to explain what a 4 and a 3 and a 2 is. So if you ever want to review that, that's there for your review. There is going to be a fair amount of introductory material just to sort of orient, but then this is what I want to show you. So for MF1, there's going to be 2 pieces here. There's the MF1 clinical skills overview. So these chapters are this will contain all of the content that's going to be taught in MF1. The weekly session guides is precisely the agenda for each week. So this is very important because there's 11 sessions, there's 11 weeks, but it's really important to understand that each group needs to be doing something fairly consistent with one another. So that is to say that each group should be teaching and practicing the same thing from week to week. There can be definitely some variation in terms of how you teach it or how you practice it or where you are, what clinic, what hospital, etc. But they really must be doing the same thing. If you follow this guide, these weekly guides, you will cover all of this material and your students will be adequately prepared. So I'm going to show you a couple of things here. And then if you go down, there's a bunch of different appendices that you can look into, but I don't want to highlight that too much right now. So the MF1 weekly skills, so these are all hyperlinks, so you can click to session 1. Session 1 will show you like the global objective, and this is to learn how to perform the components of the history, and the agenda, introduction to clinical skills, and it says a couple of things here. But it's actually really simple, you know, introducing what a history is, doing a little bit of practice. And then when you go to session 2, introduction to the effective patient or physician-patient communication, again, it gives you the global objectives, it gives you an agenda of what to do and how to practice, and then it gives you some stems that you can use with your students to practice. Session 3 is the history practice week and integration. So again, it's an opportunity to practice, and you'll see that this is a recurring theme, that we want the students to have quite a bit of time to practice with one another. Session 4, this is when we introduce the physical examination and the vital signs. And you'll see sort of the pieces of the agenda here. And you also see, just as a quick FYI, that there's always this feedback, right? Like, how did the session go? What worked well? What can we improve? I think it's critical to always brief and debrief with your students. So get an understanding of like what they want to do, what they would find helpful, and how you can work that in. But then also, what went well at the end of the session? How did it go? Is there anything you would have changed? And then this allows you to redirect or direct in certain ways to achieve a self-directed learning goal, right? So this is one of the things I wanted to talk to you or show you in terms of that diversity and inclusion piece. So you see, this starts to get into the physical exam, and there's a pro-comp connection. So remember, professional competencies is part of the curriculum that looks at things around ethics, communication, professionalism, etc. And there's a little primer here on patients of varying body habitus. So you'll see that there's some stuff to read, a little bit of stuff to read. There's some references if you need them, but then there's just some simple discussion questions. And if you go up to the agenda, you'll see that this is a specific type of structurally vulnerable population, and a couple of very important questions to discuss with the students. And this could be really, really helpful in thinking and reflecting for yourself as a clinician in training, and for the students about how to integrate these components into the everyday history and physicals that we perform. And I want to see, so if you go down to session 6, you'll also see that we've included a JAMA article, right? Does this patient have community-acquired pneumonia? And you see it's supposed to be a discussion. The nice part here is that this is a way that we can include things around evidence and likelihood ratios and just sort of getting a bit of an understanding of what you use that for and how it is related to your ability to do a history and physical examination. I'm showing you a lot of stuff. I do appreciate that. I want to show you too, whenever you introduce an exam, there's a direct observation of clinical skills checklist. So if you click to it, you'll see that this is the cardiac and hematological exam, and there's 2 for each chapter. And this is basically an opportunity for students, if they actually want to be observed, which they really should be observed and these should be filled out. You can see the different things that they've actually done. Whether you observe, a fellow student observes, or in some way on a clinical rotation they get this done, it allows them to keep track of the things that they have done and haven't done. And you might not be able to do all of these. I mean, the vast majority of people probably don't even feel for heaves and thrills or auscultate for carotid bruits or a carotid upstroke. They don't palpate for that. But it's important pieces of the exam that you can try to include as best as possible. And then we do the head and neck exam, and you can go through all of this. So there is a lot of stuff that's included in here. Remember, like, this is a 100-page document, and if you go to this section, everything's included on this. You'll see too, where's a good example here if I can show you. So this is the physical examination for the peripheral vascular exam. Actually, it's a focused history. This is how to do the history. But I want to show you that there's even things about why you would check for certain things on the physical exam. And those are highlighted in blue. So there's a lot of neat stuff. And then you'll see some modifications for patients with obesity. And we have similar inclusions for people with varying, for example, like trans-sensitive care and people with disabilities. And then you'll see that we also include some, JAMA and clinical decision-making details, just so you can sort of get into the evidence and likelihood of why we do certain things and what's useful and what's not useful. So there's a lot here. I'm not going to go through all of it. You could peruse it, but I would just go by week and look at the different things that you can do. So that's the Clinical Skills Manual. A couple of more details. There's going to be evaluations. There's a mid and end of unit evaluation. So our evals are taken care of by a software called MedSys. So one of the preceptors will actually receive an email via MedSys when the mid and end of unit evaluations are due. Now, this is very important. This process is very, very, very critical. It's paramount that it gets done on time for purposes of accreditation. If your evaluations are not done within 2 weeks of them being stimulated or initiated, it can actually threaten our accreditation at the next accreditation cycle. I know that might sound like high stakes, but it's true. If you have not done the evaluation and the 2 weeks is starting to come up, you will hear from us with a little bit of a heavy-handed, please get this done right away. But my big ask is that you get the mid and end of unit evaluations done ASAP. It's very important too to understand that if you are doing an evaluation and you put something like a provisional satisfactory or unsatisfactory, that will get flagged and sent to myself and the director of the medical foundation, and we will be following up on it. So anytime you do it, it's really important. Anytime you have a less than satisfactory eval, you need to be able to back it up with an educational plan. But that's not to deter you from doing that, but just understand that it does flag in the system. Regardless of mid and end of unit, we always say that these should never be surprises. So you should be doing weekly direct observation and providing feedback on a regular basis. So every week when you're doing a clinical skills session, you should be observing students, giving them feedback, and giving them important pointers as to what they should do, what they shouldn't do, what can they improve on, etc. So when it comes time to receive the feedback, it's not a surprise, and that's often the best way to do it. Professionalism's, it hasn't been so much of an issue in the past, but this is around dress code and professional conduct and communication, language, interpersonal. So I would ask that you encourage students to dress appropriately and present oneself appropriately. The way an individual physically interacts during an examination or speaks to a patient, I think needs to be done in a professional and sensitive manner as well. And if there's ever any major concerns about professionalism or even subtler things that you're not sure the answer to, please let me know. So for example, we've had scenarios in the past where someone has an exposed tattoo and whether or not that's appropriate. And the vast majority of the time that absolutely is no issue as long as the content of the tattoo is not something egregious or offensive, which we've never seen to date. Or there's questions around shoes. Can they be open toes? Or what about jeans? What about white coats, right? So generally speaking, we ask that there's like closed toe shoes and anything that covers the legs and the torso or the upper body should be appropriate and professional and consistent with sort of like business casual wear. It doesn't have to be over the top. And students are not obliged to wear white coats during clinical skills. Scheduling, so normally the clinical skills is 2 to 3 hours per week. That's one session. The vast majority of the time, there's a bit of variability from week to week because residents will have call schedules and different things that they have to do, so they can't commit to one night every week for 3 months. But it's usually on a weekday evening after work, so somewhere between like 4 and 10 p.m. on a Monday through Thursday. Sometimes groups do it on Fridays and weekends. I would generally try to steer away from that because most students like to go away on weekends and that sort of thing. So if you have to and it's agreeable with the group, that's fine. But it's important to understand that this is a mandatory part of our curriculum, right? Which means that they have to come to clinical skills. They cannot miss more than one session. If they miss more than one session, then they have to provide a leave of absence and they'll be expected to do remedial work. So I showed you the mandatory parts of the curriculum, which were pro-comp, tutorials, and clinical skills. Students will often have interest groups and different types of electives booked or horizontal experiences or conferences. Technically, they cannot miss clinical skills for these things. And if they do, they have to do an LOA. And if they have more than one missed session, it's remedial work, right? So you can always be flexible, but I think that only goes so far. And I mean, if there's going to be 7 to 8 students in a group, they have to be understanding as well. The vast majority of the time, this is not an issue, but I just raise it and bring it to your attention. There's an FAQ sheet that you're going to be receiving in an email. And this is going to have a lot of details about things like who to contact for bookings, how the SP program works, how you're going to get paid a stipend for doing this, who to contact, people to be aware of, that sort of thing. So I want to thank everybody because clinical skills is one of the most admired parts of the curriculum by the students. They love it. It's the closest to feeling like a doctor that they really get. They wear their stethoscope and they come in clinic type clothes and they're interacting with real people. And generally, residents love teaching clinical skills. We have very positive feedback on this part of the curriculum. You're going to be role modeling for sure, and you're going to play the role of a mentor for a lot of these students, telling them things about medical school and residency planning and all sorts of interesting conversations. There's a schedule, there's a manual, the students have access to it as well, everyone has it. You can be creative, you can sort of develop different things, like some preceptors put together interactive PowerPoints or MOSCIs where they organize a mini OSCE for their students. That seems to be very popular. There's a lot of different ways that you can teach and deliver the content in your own creative way. So I would encourage everyone to do that. And I mean, there's always questions that come up at the end. If you ever have anything or need anything, just email me at jason@profeto.ca and I would be happy to help. On that note, I will end it there and best of luck and we'll be seeing you shortly.